And welcome back to Health Watch. Today we're going to be talking about some common disorders of the shoulder, and as our guest we have Dr. Ray Jergan. Welcome back to the show, Ray.
Thank you.
Ray, we're kind of working our way up to the arm with you. I know we've talked about some wrist and hand problems, but the shoulder problems are probably one that I would think is more common to people. We're all talking about people with rotator cuff tears and problems with shoulder pain, and we've all had those kind of things. So I thought today we kind of talk about some of the more common disorders, your approach to them. And so let's just start out with some of the things that you're more commonly seeing. What's a common complaint you may see with people coming in with shoulder problems?
Well, certainly most of the people who come into the office are complaining of pain. Sometimes there's been an injury, sometimes it's a chronic problem without necessarily an injury. Oftentimes patients have pain during the day with activities, sometimes they have pain at night, depending on what the problem might be.
And where is it particularly located? Can you know by the symptom pattern what you're talking about?
A lot of shoulder pains are vague. It's not necessarily something the patient can point to and say this is where it hurts, although sometimes they do. So there's a lot of different shoulder problems that can present with similar type of discomfort. So we really need to get more detailed history and physical examination and then diagnostic studies to help determine what the diagnosis is.
Right. And I guess we've all had shoulder pain at one time or other, sometimes with activity, sometimes not. But are there symptoms that are associated with certain movements that give you a better approach to what you're dealing with?
There are. Today I wanted to discuss some problems with instability of the shoulder, also some rotator cuff disease, and degenerative arthritis, and each of those has its own symptom complex.
Well, let's just talk about that. You talked about this instability. Talk to me about that.
Well, what I'd like to talk about is just show you a little bit of the anatomy here. This is just a model of the shoulder that shows some of the muscles that form the rotator cuff tendon. The rotator cuff goes around the ball portion of the shoulder. It is formed by 4 different muscles, which then become a thick fibrous tendon. The tendon attaches to the bone, and when these muscles contract, the arm moves into different directions. It's elevated or rotated, and they're important in supporting the shoulder. Deeper inside of the shoulder, we can see, that's a little hard on this model, but the socket called the glenoid is very flat. This is a ball and socket type of joint, but it's different than a hip. A hip has a round socket and it's very supportive of the ball, whereas in the shoulder it's more of a flat socket, and therefore the stability of the joint really relies on soft tissues to support it. So deeper inside here there are a series of ligaments that hold the ball to the socket. Those are attached around the rim of the socket, and the rim is called the labrum. The biceps tendon also attaches there. Sometimes we may have someone who's been injured. They may have stretched their shoulder or dislocated it and torn ligaments, and sometimes that then sets them up for instability problems where maybe they would go to throw a ball and feel as if they're having a lot of pain, or maybe something's slipping out of place, or it could completely dislocate and come out of the socket again. Some patients are just born with loose ligaments, and females are a little more prone to that, but we see it in males also. Typically these problems are seen in younger patients, usually teenage years, 20s, a little less common in the 30s, and rarely do we see instability problems after 40. So most of these patients will have pain, and usually it's activity related.
Right. I would always think about, especially when you bring it up like that, how how necessary all those things have to work to keep it in, because it's not like set into a nice socket where it can't fall out like the hip. This thing is depending on a lot of factors to keep the shoulder in. So I wonder we don't see more of it.
It is a fairly common problem, yes. And
are there sports that are associated with specifically, and I would think of tennis as one of those, or for that matter, a baseball player, a constant use issue? Is it one of that, or is it really other factors?
It can be. Certainly we see dislocations occur with the contact sports, football and hockey and that sort of thing, much less commonly in something like tennis or swimming. But patients who are repetitively using their arms in tennis or swimming can gradually stretch those ligaments out, or baseball pitchers. and then they can develop an instability that can be more of a gradual onset.
Right. You mentioned injuries. If you had an injury, is that more likely to promote that, more prone to do that later on? And
Yeah, definitely.
once you've done it, it's you got a problem.
Yeah, it's hard to get these to heal exactly back where they were before, although most of the time patients who have had dislocations do not require surgery.
Yeah, talk to me about that. What would you recommend? Your diagnostic techniques as you approach somebody like this. Is there anything specific you need to do?
Well, once we have the history from the patient, then we examine them and try to determine on physical examination whether the shoulder seems loose or looser than it should be. And if the patients do demonstrate some of these instability signs, then usually the first treatment would be to put them in a physical therapy program, try to strengthen up some of these surrounding muscles. You can't really tighten up the ligaments that are loose, but if the muscles are made stronger, or sometimes the muscles are just out of balance as far as their strength, and if we can improve the balance of the muscles, then that may improve the instability symptoms. Sometimes patients are willing enough to modify their activities so that they don't overstress their shoulder, and they might be fine with that. But if there's a patient who fails to respond to those treatments, then surgery is indicated. It depends what kind of instability there is as to what type of surgery we do or what part of the shoulder we need to work on when we do a repair. But basically what we're doing is trying to tighten up the ligaments, the capsule, and if that labrum is detached from the socket, from the glenoid, then we like to repair that back down to the bone. If we're able to look into the shoulder and just see the socket, it's quite small, and these ligaments all attach there. What we like to do is take one of these, or several of these little devices. These are called suture anchors. They're like little screws that are we make drill holes into the bone. These screws are then passed into the bone. The sutures are then tied around the ligaments and the labrum, and we take a little tuck in the tissues. We put multiple anchors around the rim, and then basically make it tighter so that it tends to reduce the amount that the ball can slide back and forth in the socket. This requires a period of immobilization afterwards so that it can heal, and then quite a bit of physical therapy afterwards. Typically it would be about 4 months until they can return to moderate activities, and usually 6 months until they can return to contact sports.
It's interesting. We've done shows on hips and knees, and the physical recovery time is shorter. The shoulder seems to be a particularly, just by the activity it has, and a longer, more protracted rehab.
That's right. A lot of the soft tissue repairs actually take longer to heal than bone repairs.
Really? Yeah. We got to take a break. We'll be right back and talk about some of the other issues. We'll be right back after this message.